It's all south. So when you go check those blood sugars, do you find that your result is below 110 in the mornings? Some of them? Then they're well controlled. But the patients that have a result that is above that 110, they're not well controlled for various reasons. Maybe it's diet compliancy. So let's just look at diabetes. Now, make sure that you understand. She had talked about a person who has diabetes has frequent urination. What is the medical term for that? Polyuria? And if you have hunger, what is the medical terminology for that? Dysphagia. And then so if you had frequent thirst, what is the medical terminology for that one?
Oh, wait, I had that
Dipsia. Polydipsia. Okay, so you see how painful it was to recall that stuff? All that stuff is getting ready to come up and you're going to be seeing it. So you have to know what it means. Yes.
always tired, lethargic.
So according to the video, you understood what hyperglycemia is. Hyperglycemia is a patient that has a blood sugar that results in 110 or above, and usually it's much above. We're going to talk about, and I think that video and some of these slides are a little bit redundant about trying to express to you what these symptoms are if you have hyperglycemia, okay? Patients that have hyperglycemia, sometimes they can tell when their blood sugar is rising and they'll start getting a headache, they'll feel sick, their blood pressure might raise, they might become weak. When it gets to the severity of being high, you can smell their breath be fruity. Fruity, that it's dangerously high. When you get to smelling that, it's dangerously high. Then, if other things happen, such as confusion or, other illnesses, they've gone into that ketone acidosis phase. And so if they get into that phase, they could potentially die. Now, hypoglycemia is the opposite. However, they may have same or similar symptoms, but there are still symptoms that are going to be different. And the first symptom is the blood sugar is going to result on the glucometer below 70. Facilities have policies in place of a protocol that a nurse has to carry out. So when you go into your facilities this upcoming week, inquire about their protocol for diabetes. Every facility is pretty much uniform to the next facility, except in long-term care, they don't have the tools such as the IVs that are available as they do in hospital. So you can understand why some facilities may vary a little. But there is a standardized protocol in place, and we're going to talk about that. But let's just talk about what the symptoms of hypoglycemia is. Physical weakness, sweating, that warmth feeling, that physical weak. Sometimes it's pronounced confusion. It could be hunger. They could feel really hungry, like they can't get enough to eat. And then once they get enough to eat, they kind of calm down a little bit, but they fed that hypoglycemic attack. Irritability, shakiness. Their heart rate may speed up. There's a lot of things that could potentially happen, and every patient is very unique. They have different symptoms. Some patients that have been hyperglycemic for so long, when their blood sugar gets close to 100, they feel like they're going into hypoglycemic episode because they can't tolerate the sugar being that low because it's never been that low. Does that make sense? So even though you take their blood sugar and you're like, you're 110, you're fine. No, they're not. They are really going into a hypoglycemic episode, and they will. So those are the patients you have to kind of tailor care to. Does that make sense? Maybe you're going to have to give them orange juice, even though they're not down in the 70s, they're 110 because of that reason. You can't always put every patient in the cookie cutter of what, things say, what lab values say, what parameters are. It doesn't work.
I sure was wondering, because a lot of the times when I do get a low, when I be at work, this is the first thing they say, oh, give them some orange juice. I'm like, wait for God, I'm like, wait for nothing. They just give them orange juice.
Yeah, and I think I've got some extra slides in here I could have cut out. I thought I did, I guess. Let's just talk about type 1 diabetes. And I'm going to get back to that statement that you just said. Type 1 diabetes is referred to as insulin-dependent diabetes mellitus, IDDM. You may also see it written. So if you see it as a diagnosis written IDDM, it's insulin-dependent diabetes mellitus. You may also see it as diabetes mellitus type 1. That's another way that you'll see it written. Now, it means this patient right here, they take insulin only. They eat, so they also use diet. Every diabetic uses diet. They're supposed to. But your type 1, they use insulin only. These patients are more prone to having hypoglycemic episodes because of the use of insulin. Hypoglycemic because they use insulin. One of the biggest side effects of insulin is hypoglycemia. And I can't even stress that enough. It'll kill them. Remember the 8 pinch? Remember the I in pinch? I stands for what? Insulin. You want to kill somebody, give them too much insulin. You know, when they put people on death row, they give them a lethal dose of potassium and insulin. So your DM ones are insulin only. So they're insulin only. And then you've got your diabetes type 2. These patients, so they're insulin and diet. These patients, not all the time, but sometimes some of them can have insulin and oral diabetic medicine and diet. And then some of your DM2s can be oral medicine and diet. The more insulin they have, the worse their diabetes is. That's how bad their diabetes is. Does that make sense? So if you've got a type 2 patient and they have insulin and oral medicine for diabetes, and you're hoping that they're compliant by diet, they're pretty bad. And worse about it is they can have 2 or 3 insulins prescribed to them. And that should tell you a lot. So for type 1, they usually will have about 2 insulins prescribed to them.
if something keeps up on having a type 2 diabetes.
No. Type 1 happens in patients that are primarily children or adolescents. So what happens is with type 1, the pancreas stops working completely. So there's no pancreas working. None. Type 2 develops later in life, when you turn about 40. It can happen before then. It can happen after. Sometimes sedentary lifestyles, overweight, genetics, improper eating or poor eating habits, those things can trigger diabetes. But remember what the video said, diabetes type 2 comes on very slow. Patients get used to it. They don't see that there's a problem because they're slowly adjusting to the problem over the course of years. And before you know it, they can go to the doctor and they're diagnosed with diabetes and they're slapped in the face, but they have no idea that they've had it for 10 years yet. Yes.
So which form of diabetes comes from when you said gestational diabetes?
Okay. Diabetes type 2. Women who are pregnant and develop diabetes, they call that gestational diabetes. That happens, and then you have your baby, and then your blood sugar goes back to normal. But what happens is later in life is that that woman will become diabetic type 2. And sometimes oral medicine will be sufficient because diet is good. And sometimes it's all of those things. It just depends. Environmental factors play a big role. And when I say environmental factors, I'm also including sedentary factors, weight, exercise, all these things. However you treat your body is how your body treats you later. You know that brand new car that you buy and you never wash it, you never vacuum it, you never take it for an oil change? What does it do to you later? Fails, has no shine. That's kind of what you do with your body. If you don't take care of it, when you get to the end, it doesn't pay you back. It just reaps the benefit of what you did all these years. Does that make sense? And it's very unfortunate when you're talking about adolescents having diabetes. How many of you have teenagers or soon to be teenagers? Tell me that they do everything you say. They don't do everything that they should be doing here. And so type 1, patients with type 1 diabetes don't live as long as people type 2. Right. Never works. It might have worked at birth and then it just stopped afterwards. But because they have poor compliancy, they have a lot of complications that end their life way before it should. And you'll find that when you're long-term care, it's very rare that you have a type 1 diabetic. It's very rare. They are 98% type 2. You pay attention to that. Come and tell me if you ever find a DM1. Let me know. It's sad. It really is.
I think his pancreas got messed up. He was in a really bad accident, but he was an adult when he was in the accident. And he's like 30, I want to say maybe 38 or something right now.
He's a type 1 because he has no pancreas.
Yeah.
He has no way to secrete any type of insulin. So he's going to fall into that category that he has to be insulin controlled. Here, every once in a while, the pancreas spits out insulin. Every once in a while, it doesn't. It's inconsecutive. And so that's how come hyperglycemia develops. The less the pancreas works, they have to move on to insulin. But if the pancreas intermittently works, oral medicine and diet alone can help. And they don't have to go to insulin. Does that make sense? Now, you saw in the video, it talked about wound healing is impaired when the blood sugar is elevated. So when patients get sick, when they have an underlying infection and they're diabetic, they become hyperglycemic immediately. that tells you when you take a blood sugar and the patient's in the 300s and they've been fine all the previous days, you better look to see where the infection is. They have a UTI, they have something's wrong. These are patients that are more prone to complications. And when they get upper respiratory problems or urinary tract infections, we have to treat them promptly. We can't let them wait. Now, having said that, if you end up in the hospital, even if you were just taking an oral med and doing diet and you're type 2, you go in the hospital, they're going to take that away and just give you insulin because they want to control your blood sugar the whole time you're there because they need you to heal and get out. And then when you get discharged, they just put you right back on the medicine you came in on. Does that make sense? That's what they do. Patients will be like, I've never had insulin all my life. And you're standing there with a syringe and you're like, well, I'm going to give you 20 units. But you go back and you look at the MAR and you're like, oh, you were oral agent at home. Because you're here, we have to keep tight control of your blood sugar. So that's why we check it so much and you're on insulin. But when you go home, you're not going to be on it. These are the risk factors that can also contribute to diabetes. Talked about that a little bit. I've explained to you about diabetes type 2. If a patient like this doesn't take any insulin, you might see them as non-insulin dependent diabetes. It means the same thing. But they may specifically tell you the patient doesn't have insulin by doing this, by abbreviating it this way. All right, so now we're going to talk about some oral agents that are used to help control the diabetes. First of all, they have a first gen, and your book doesn't talk about it. It's not there. It is on your paper, but it's just on your paper. We're just going to talk about it, okay? Now, the fact of the matter is that these will carry on a lot of drawbacks and complications. They cause more problems creating hypoglycemia for the patient than they do benefit. So we don't use these drugs, but they're out there. You may recognize them. The second generation drugs are the very commonly used drugs. So Amaryl, Glucotrol, Diabeta. For those that are CMTs, you see those drugs, right? Mm-hmm. They're the second gen. When patients take oral medicine for their diabetes, they have a less likelihood of developing hypoglycemia. Could they develop hypoglycemia when they take an oral agent? Yeah, they can, but they're less likely to. Here's another one. Meglitinides, analogs. Starlex, for example, is one of these examples. Prandon's another one. These oral agents, specifically this one, they help to stimulate insulin secretion from the pancreas, which will lower the blood sugar. Now, if the pancreas doesn't stimulate any insulin, it can't make insulin. Does that make sense? So your pancreas has to be making some type of insulin. How do they know that? Through a lot of lab testing. Here's one. Biguanide, metformin or glucophage. Have you heard about this one? Does she? Yeah? Metformin? So, and it's true that there are a lot of oral agent anti-diabetic medicines, and each of these are from a different group. So you know what? Your patient could be on metformin, they could be on Starlex, and they could be on Glucotrol because they're from different groups. They won't be on two medicines from the same group. You said they can't be? They won't be. But they may be on one medicine from each group. The more meds that are on, yeah, the worse it is, yes. And so sometimes they do that to try and prevent them from getting onto insulin. Yeah. Now, would you prefer to take a shot or 3 pills? Give me 3 pills, right? Well, they can give injections, but a lot of patients, quite honestly, prefer the oral agents. It's way cheaper than injections. When we start getting into injections, the cost starts going up. The insurance starts telling us how many syringes they're going to cover in 30 days. I mean, so patients start reusing their syringes, and then that increases risk for infection. Do you see how this can go? There are a lot of meds, and glucophage is one of those, that if a patient's going to have an MRI with dye or a CT with dye, this has to be held. What's that? Oh, it did? How'd that happen? Okay. So, usually the radiologist will mention, that they have to be off of it 24 hours before they have a test done. Like an MRI with dye or a CT with dye. Then you've got, here's another class. Thiazinidinodienones. I don't know. Anyway. Avandia or Actose. These are insulin sensitizers. Now, the problem with these drugs is they have major side effects of causing or contributing to weight gain. So patients come back 45 pounds higher. And it's great. It's great for somebody who's had significant hyperglycemia and they've lost a lot of weight. And they send them home on this. And then they come back and their weight is better. And then we change it to something else. We just don't tell them that's the side effect. Because you know what it is? If you tell me you're going to give me meds, it's going to cause me to gain 30 pounds. I'm not going to take it. What'd you say? It's the one before. Yeah, they won't tell you. I know when they first started giving it, I worked in a doctor's office and the patients would come back and they'd be so much thicker, but they looked healthy. I know, they looked healthier because when you have hyperglycemia, they become very skinny. They burn fat all the time. When you start getting your blood sugars managed, the patient usually will gain or maintain the weight. Yes, they get their cushion back. Here's some alpha glucosidase inhibitors, Prandos, Glycet. I don't see those too much. Tell me, CMTs, are you seeing those drugs?
I've never been.
No, I haven't been seeing them. What about Jardiance?
Yeah.
We're hearing it all the time, aren't we? Yep, it's on the commercial. Yep. So when you've got Jardiance, I'm trying to find it. It's a sodium glucose con-transporter. It's also known as an SGLT2 inhibitor. What page is it on? Class sodium glucose inhibitor. That's on.
Oh, this seems like a very nice.
Which one you see there?
Like the.
Oh, yeah. So every drug starts out with a chemical name because they're made as a chemical first. And then they are created into what we begin to understand them to be when they get on the market, which is Jardiance. Yes. So what page did you guys find Jardiance on? 338. Thank you. Because I lost my page number. Mm-hmm. Mm-hmm. I think it's 337 on mine. There we go. There we go. Jardiance. So it's 10 milligrams orally, daily in the morning, and it's taken with or without food. And it may increase up to 25 milligrams. Most of your oral agent medicines are given right before breakfast, right before dinner. So they're given at 8 o'clock in the morning, and then they're given again at 4 o'clock in the afternoon. But Jardian says give with food. Well, this is the thing.
So you tell them that so they can bypass the.
Do you know how hard it is to get people to comply to take medicine before a meal? Because they're afraid of it making their stomach upset. And so what happens is patients that are on these oral agents, they'll just wait until they sit down and eat. And then if it's instructed for a patient to take it before a meal, that means on an empty stomach, right? So if they take it with a meal, do you think the medicine has as good as a benefit to them? So, you know, you've got all these chemists that decided, oh, let's make a pill that it doesn't matter if they eat or not, that they can take, and it still has the great benefit, right? And it helps better compliancy, keeping hyperglycemia under control. So here they come out with this drug. It's probably pretty expensive. Not all insurances cover, but guess what? It's going to become available as a generic to the population after 7 years. And they're still going to win money. They're still going to get money. So that's kind of what we're looking at. Then we have, and I know that you've been hearing about it, Trulicity. Some of you this week that had clinicals had a patient that was taking Trulicity. So that's just 1 time a week an injection. Does that tell you that the half-life is very long? Does that tell you that the patient, if they experience hypoglycemia, you might be fighting that problem? Right? But Trulicity is having good results, a good outcome. It's not really contributing to a lot of hypoglycemic episodes from what we understand. It is an IM. No, it's a sub-Q injection. It is a sub-Q injection. And all your insulins are sub-Q. All of them. Januvia. This is another one. As I said, all your oral agents, you have to be excreting some type of insulin from your pancreas in order for them to work. If the patient takes them, and they start developing hyperglycemia, likely that they don't have any more insulin that's being secreted. And that's how come they get transferred to having insulin injections, because insulin injections can control the blood sugar a lot quicker and better. So what are some of your patient teaching? Teach the patient, take this medicine exactly as it's prescribed to you. Make sure the patient understands how to administer it. If it's subcutaneous injection, teach the patient how to give themselves a subcutaneous injection. We teach the patient to give themselves an injection in their abdomen because that's an easy reach place. Does that make sense? What degree do we teach them to use? All right, and sub-Q is at what degree? 45 degree. Is it wrong if they do 90 only if they're thick?
No.
Right? But, you know, when you go in to teach a patient, plan for 45. And when you see them and they're a thick person, you can teach them 90, right? But you also, what happens if they lose a lot of weight and they still do it at a 90 degree?
So you gotta reteach them to do it at the 45.
Right, but maybe they lose the weight before they come back.
So just teach them the 45.
Just teach them the 45. Be done with it. Does that make sense? They don't need to know anything more than that. Do it at 45 degree angle, period. Right? Exactly. You gotta be able to predict that. Sometimes when you give patients too much information, it comes back to bite you that you shouldn't have done that. Right? Just tell them it's like this. These medications cause 50 million side effects, right? Just one of them. So the patient says, okay, what kind of side effects can I expect?